Dr. Hugh Kearney completed a PhD in University College London investigating the use of spinal cord MRIs in MS and its association with disability. He completed his clinical training in neurology in Ireland, including a 2-year postdoctoral fellowship in genomics with Future Neuro. He currently works as a consultant neurologist in St. James's Hospital and is leading the MS unit there. He's also part of the academic unit of neurology in Trinity College Dublin and is developing a research group focused on transitional research in multiple sclerosis, including the development of diagnostic biomarkers. So Dr. Kearney, it's a pleasure to have you here with us this afternoon and to speak on this topic.
Thanks very much. So I'm just going to share my screen here.
Perfect, thank you. Yeah, that's up now.
Great.
Wonderful, thank you. And sorry, just to remind people that if they have questions, they can send them through the chat function or through the Q&A, and we'll address the questions towards the end of the session. Thank you.
Okay, great. Thanks very much for the invitation to take part in the conference today. My name is Hugh Kearney. I'm a neurologist in St. James's, and I'm also involved in research in Trinity in Dublin. So what I'm going to do is talk a bit about white matter first of all, then some questions about MRI, then talk about grey matter changes, and lastly discuss smouldering MS, which is sort of a newly emerging concept, and then wrap things up. So begin by talking about the white matter in the brain and diagnosis. So when people have a first symptom of MS, these are very different from person to person, and how someone describes it or experiences or what they recognize as something that's strange or different can be very different from person to person. And we know that oftentimes people might not recognize the symptom at the beginning, and it's only after the diagnosis they go back and they say, that episode 4 years ago or 5 years ago, that was probably the beginning of something, but I didn't know it at the time. So we'd often hear that story in clinic. One of the things I suppose that we would do is, if we hear a story from somebody and they've been referred by their GP with a suspicion of a neurological problem, one of the first tests we would do is an MRI scan. And this is particularly if we think the story matches up with what we understand as a symptom of MS. So I've just given a small cartoon here below, and these are some of the symptoms, but there are many more than this. Things like fatigue, changes in cognition, sometimes weakness in muscles, changes in bladder or bowel, sexual dysfunction, visual problems, vertigo, or changes in mood. And as you'll have heard over the course of the day, many more things can occur, and you may experience some of these things yourself. So this isn't a complete list, but it's just some of the things we'd commonly recognize. So once we go on to do an MRI scanner, there are often many questions about MRI. So I thought this might be an opportunity to talk about it a little bit because it's relevant to the talk today. So first of all, what is MRI? So it stands for magnetic resonance imaging. And basically, this is a picture of the scanner here on the left. And any of you will have had a scan for diagnosis or for monitoring will be quite familiar with this. Basically, what this coil is here at the end is a giant magnet. And how strong the magnet is depends on where the hospital is, which scanner they've bought, and there are different manufacturers. So it's a lot like any technology, like a television set or a camera or whatever. There are a number of different companies and they all have different pros and cons, I suppose. But ultimately, once you're on the table, what happens is this magnet, it excites the water in your body, because our body is mostly made of water, and the magnet can pull all those water molecules into a line so that they're spinning together. Then you turn off the magnet, and this allows the water to relax. And when it relaxes, that energy that was contained has to be given off. And that energy that's given off is read by the frame that's placed over your head at the top of the scanner here. And then a computer converts that signal into a picture. And that's really, in a nutshell, how MRI works. So this is what a radiologist or a neurologist might see in somebody who has MS. So these are sort of a couple of examples of slices from a brain scan. And what I've done is just put yellow arrows at the bright spots here, showing a number of different locations where these might occur. And these, like everything else, will vary in number and size, and there'll be a great degree of variability from person to person, but generally there are particular locations that we'd be looking for these changes to occur if we think somebody has MS, or then if they have MS, we'd be looking to see if anything new has happened or if everything is stable compared to the previous scan. So, like a lot of things in life, there are rules for this, and these rules for diagnosis are called the McDonald Criteria. And these kind of what are internationally accepted for making a diagnosis of MS. So usually what happens in most cases is somebody sees their GP or maybe another hospital doctor, they're referred to a neurologist. The neurologist would get the story from the person, examine them, and if it all matches up, they'd get an MRI scan. And if an MRI scan meets these rules for lesions in particular locations and numbers, then it can be said that these criteria are fulfilled. And what would happen in many centres, certainly where I work in St. James's, is that we'd have a weekly meeting with our radiologist, and that way we can sort of review the images in detail, and then the radiologist has an opportunity to ask more about the symptoms and see does the scan really match up with the story that the person has told in the clinic. So the next thing I thought I would talk about is some questions about MRI results, having just given an overview of MRI there. And the reason for this is that this is one of the things we're most commonly asked about in clinic. Myself and Martina, who's the nurse specialist who works with me, would very often get questions about MRI scans. And I'll go through a few questions that we'd typically be asked and hopefully try and answer them. So the first thing really to say about MRI is that at the moment, it's really the only clinical test to monitor MS activity. So what I have on the right here is a screenshot from how we characterize MS. So if you focus on the bottom here, we have relapsing remitting disease, and it's broken into two categories, so either not active or active. And this is one of the most important things we're trying to answer every time somebody's in clinic. And the reason is, if somebody's MS is not active, that means the treatment they're on would appear to be working, and there's no need to change anything. But if somebody's MS is active, it might mean they're not on any treatment, or if they're on a treatment, they might need something stronger. So then the question is, how do we say someone's MS is active? So there are two ways. One way is if the person has had a relapse, and the way we would find that out is we would ask the person about new symptoms, what's changed, what's new, what's come up since the last time we saw you, all those kind of things. And if they say they've something new that they've never had before and it lasted for more than 24 hours and they weren't sick at the time, then we'd say that that might well have been a relapse. Now, there's no test to confirm a relapse, so it's based on the story alone. But examining the person, there may be signs of a change compared to the previous examination. If the person hasn't had a relapse, the other way we can see if things are active or not active is with an MRI scan. So in many centres, a scan will be done once a year, and this is a way of monitoring the effect of treatment. So what would happen is the scan is compared to the old scan, and if there's a new lesion or one of the lesions has grown bigger, then we'd say it's active. But if everything's the same, we'd say it's not active or it's stable. And that's really how MRI feeds into this. So one of the first questions we'd be asked commonly in clinic is, does the number of lesions matter? And the answer to this really is that it's not the number of lesions at any point in time. And the single most important factor is the rate of change. So if the scan is read as stable and there's no change, that's good news. But the time point where we would want to act is if the number of lesions are growing from 1 year to the next. And we know from previous studies that if the number of lesions are growing from 1 year to the next, this is a risk factor for progression of the disease down the road. And so that if that sort of circumstance arises, it'll be very important to act, to discuss it with your nurse specialist and discuss it with your neurologist, because it may well mean that the treatment needs to be considered. So that's probably one of the most frequent questions we'd be asked in the clinic. The next question we'd be asked would be, how big are the lesions? And again, a bit like the number of lesions, the size of them isn't necessarily an important factor, because we know from research studies that if you look at the size of the lesions or the total volume of them and how the person is by examining them, there isn't much of it. The two don't really match up in terms of levels of impairment. But what we do know is if you follow up scans over months or years, generally most of the lesions will shrink. Now, they don't always shrink away entirely, but they do decrease in size, and they tend to get smaller with time. And again, it's really only if we see things going the other way, that we have an existing lesion and it's getting bigger, that's when it would be a concern. So we would sort of look for new lesions and we'd look for enlarging lesions. And they're the two sort of MRI approaches to saying that someone's MS is active. And what if the scan is stable? We'd usually sort of present this as good news, because it means whatever treatment is being used would seem to be working. If the scan is stable, it means that someone's MS is not active, and we'd usually say to continue the same treatment and keep everything under review. And if there are any worries or concerns in relation to symptoms, then to contact your MS nurse or your MS team and then discuss any concerns you might have. But generally, a stable scan is good news. And then the last sort of question we would be asked is, what if my scan shows new lesions? And I've kind of addressed that a little bit already. The first point that's important to discuss is it may be a case of timing. So no matter what medicine you use in MS to treat the disease itself, there's a lag time between the medicine starting and it for it to fully kick in and take full effect. And that can be anywhere between 6 months, 10 months, or even up to a year or beyond a year. And if you do a scan before the medicine has taken its full effect, then sometimes you'll see changes. And that doesn't mean the medicine isn't working. It just means it hasn't had a chance, if you like. So the timing is definitely important if you're going to do a scan. And then if you're sure enough time has passed and you're definitely in a time point where the medicine has taken full effect and there are changes seen at that point, then it has to be talked about or discussed about changing to a stronger MS treatment. And this might mean maybe changing from an injection to a tablet, or from a tablet to an infusion, or so on. And it very much depends on individual circumstances. It depends on any other medical conditions or any other medicines that are being used. So there are lots of factors to consider here. And a key point always is the safety, because you don't want to put somebody on a medicine that isn't safe. And sort of the key link person or liaison, as many of you will be aware, will be the MS nurse. If your scan is active, a neurologist or an MS neurologist might say, this is the next treatment, I think that will be good. And oftentimes the way we would do it in St. James's is that our MS nurse would then schedule a call with the person and then discuss the ins and outs of the new treatment being discussed. Make sure that the person understands all of the pros, the cons, the risks, the benefits, and then make a decision as to whether they wish to go ahead. And we'd get things in place then if everything seems to be okay. So the next thing I'm going to talk about is grey matter changes. And this is slightly different from what we've been discussing so far. So just to sort of show a cartoon of the brain, in this is a cross section through the brain. So we can see the smaller picture on the right, and there's a black line through. And what you can see is inside of the brain, there's the white matter. And then on the outside, on the lining, is the grey matter. And what I've been talking about so far with MRI and with lesions on scans has all related to white matter. But the grey matter in MS is actually very important, and it's a thing that's been talked about for a long time, but maybe not always in a clinical basis. And I'll go into why now. So what I'm showing here is a cartoon, and really it's image A at the top that I want to kind of draw your attention to. So what image A is, a group of researchers in Austria studied 50 brains of people with MS who had a post-mortem. And what they studied was, where is myelin lost? So myelin is the coating on the nerves. And what they did was they made a composite, or an average, of all of the brains in a computer program. And then they mapped onto this computer program with color, so like a heat map. So the red represents more loss of myelin, and the white or the yellow is less loss. So what you'll see if you focus maybe on the outside of the brain, you can see in this sort of dip or curve here, which is called the insula, there's a lot of loss of myelin, or just on the inside here, which is called the thalamus. And then down along this strip, which is called the cingulate gyrus, there's a lot of loss of myelin. And the degree of loss of myelin here on the outside in the grey matter is actually far greater than what's seen on the white matter. So the question is then, why do we always do scans on the white matter if the grey matter is actually more important? And one of the reasons it's really to do with the technology of MRI. So at the beginning, I talked a little bit about how does MRI work. One of the things in the brain is that myelin contains water, and there's less myelin in the grey matter than the white matter. So it tends to give off less of a signal. So when it gives off less of a signal, you don't see it as well. And then if there's a change in that, it's harder again to say, is that change compared to the normal circumstance? And that's really the background to grey matter changes. Now, this is a question that would often arise. You know, many people would be aware that the grey matter is important. So what I've shown here again is an example of a scan of somebody with MS. And this is a cut through sort of close near the top of the brain. And I'll just draw the arrow around the outside here. So you can see the way the outside of the brain, the cortex, which is the grey matter, it's a tiny bit brighter compared to the inner bit, which is a bit darker, which is the white matter. But even at that, drawing way around and actually seeing it relatively clearly on the scan, you don't see any lesions or marks or changes. But what I've done is inserted some arrows here, and all of these arrows show lesions on the white matter. So even though we know for sure there are lesions in the grey matter here, and there are lots of changes, we're just simply not seeing them on the scan. So the hospital scanners generally are very, very good at seeing the white matter changes. They're very sensitive to picking up new changes, bigger lesions, new lesions, all of those things that feed into the discussion about treatment. But generally, the hospital scanners aren't great at showing the grey matter changes. So that's why it wouldn't necessarily be something on a report or something that's been discussed with you. There are research approaches to this, and really research has focused on this for quite some time. And they're one of the sort of biggest drivers for doing research in this area is to do with the diagnosis of MS. So MS, as we talked about, it starts with a story, the story from the person, examining the person, and then doing a scan. And seeing, does the scan match up with the story from the person, so that we know that it all lines up and makes sense. And then we apply the rules, as I said. But the scan is focused on the white matter. And for many other brain diseases, sorry, I beg your pardon, the white matter can change. And the most recent version of the rules does allow for picking up in changes in the grey matter. So these are two scans. So the scan on the left, which is image A, is called a double inversion recovery. So what this does is it sort of makes the white matter disappear, if you like, and it makes the fluid disappear. So you're just sort of left with this outline of the grey matter. And if you see these circles here, there's one here, one here, one here, 3 circles, and there's a smaller, brighter area within the cortex. And that's what a cortical lesion would look like on a scan. Then the scan on the right here is called a phase-sensitive inversion recovery. These are all technical terms, and they're not so important. But ultimately, the point of this is, with these sort of more advanced research scans, you can see the grey matter lesions. So they are visible in a research setting. There are problems with these scans though, and one of them is how long they take. Not all the scanners can do them, and they tend to work when you have a stronger magnet. So not all the hospitals would have a magnet that's strong enough. And it's hard to sort of standardize the approach to this. So it remains very much a tool used in research. There are, I suppose, some questions that come up from this. So why are the grey matter changes important? Well, as I said, the grey matter changes on MRI, they are included. So if you do see them, even with sort of the technical limitations we have, they can be included for the current rules for a diagnosis of MS. And the second thing is white matter changes can be seen in lots of different brain diseases, but the grey matter is quite specific for MS. So if you could see the grey matter, you'd really improve the accuracy. And accuracy of diagnosis is so important, because you don't want to diagnose MS if that's not the case, because it's just as important to rule it out as to rule it in. So a question that arises is, why are new MRI techniques needed? So what I have here are a series of brain scans. These are all very different diseases. So there are 5 different brain scans. You can see at a quick glance, they all have changes. They all have changes in the white matter, and they all have what we would describe as lesions. But only one of the scans has MS. So you could see maybe if you didn't have a background in neurology, or you didn't have a radiologist familiar with the particular rules in MS, how this can be challenging. So I'm going to show you the answer now. So the only scan with MS is the scan on the left. This is a scan of somebody with migraine, and this is a very common reason why people would be referred to a neurology clinic. Somebody with migraine often gets an MRI scan either through their GP or a hospital doctor. The scan frequently shows changes, and then a radiologist's report might say these changes are concerning for MS. But it really then is a case of going back to the story and talking to the person and seeing, do they have symptoms that look like MS? This is a genetic condition that's uncommon, but it does cause changes in the scan. This is an immune condition, which is called SLE, or lupus is another name used for it. And these are changes of somebody who's got many years of high blood pressure and high cholesterol. And this is kind of why the focus on the white matter needs to be thought about and in research. So I'm going to talk very briefly about a research study we're running at St. James's at the moment. And this is a study called Multimodal Evaluation of the Diagnosis of MS. And what we're doing is developing 3 different tests and trying to see, with these different tests, can we improve the accuracy of the diagnosis? So one of the things as part of this is a scan. We're trying to develop a new technique. Now it's in its very early stages. We have a long way to go, but we're hopeful that this may be a step in the right direction. The difference in this project is, rather than trying to scan the whole brain, we went back to that heat map I showed you a few slides ago and looked at where are the changes greatest in the grey matter. And then what we've done is we've really zoomed in on those areas a lot, so that we're looking at a very high resolution to see, can we pick up the changes in the grey matter. So this is an example of a scan. Now, this is a very early pilot study, and some people with MS and James's have very kindly given up their time to take part in this study. So this red arrow here shows a lesion in this part of the grey matter, and another one here. So this is kind of a promising result. It's, as I say, it's from a pilot study. We're at the very early stages, but we're hoping to roll this out over the course of the coming year and do it on a more wide-scale basis. And if these results go the right way, then we're hopeful that this technique could potentially lead to an improvement in diagnosis in terms of accuracy, and then putting the attention back on the grey matter rather than the white matter in MS. So the next topic that I'm going to talk about is about what's called smouldering MS. Now, I suppose the first thing is that what do we mean by smouldering? So the term kind of came from fires and sort of that kind of idea. What we know is that as you might know yourself, if you have a fireplace at home, you can have a full fire going where there's flames. You can see like on a barbecue where things are glowing, or sometimes things are just smoldering away. So it's just black, the coals look dark, but there's definitely heat coming off it and it is burning away. So this kind of term became incorporated because at the moment, what we really have is a situation where we define MS as active, which might be sort of thought of as sort of flaming, or not active, where you're out here in the grass and nothing is happening at all. But there is this sort of situation in the middle where things aren't really fully lit up, but they're not said to be normal either. So there is something happening, and it's kind of causing these slow, gradual changes. And it's become increasingly recognized that this phenomenon plays a role in these very slow changes that people might experience. So we know that many people with MS describe a very slow, subtle change in their function over many years. So it's not a quick thing. This can happen without any sort of big, definite relapses. And we know now from recent studies that this phenomenon, it can even happen when people are on quite effective treatment. So when somebody's on treatment and they're not having relapses and their scan is stable, sometimes some symptoms can kind of come out a little bit more over the course of 5 years, 6 years, that kind of a time span. And what we would now say is that this process of change is probably as a result of this phenomenon known as smouldering MS. Now, to kind of delve a bit deeper, this is some pictures of the pathology of different lesions of MS. So what you see here are some stains for myelin. So you can see the way where the brown is normal myelin, and where there's white, there's loss of the myelin. And then the same here on C and on E, this is myelin, which is stained, and then there's the white where it's lost. Below is a separate stain, and this is to stain for the immune cells. So we're not seeing, in an inactive lesion, we're not seeing much immune cells. So in other words, this is kind of burnt out, nothing more is happening. In what's called a chronic active, there are still immune cells. So you see these purple dots, these fellas are all sort of busy working away. They're kind of very slowly edging away into the normal myelin, and they keep sort of edging out bit by bit by bit. Then there's the active lesion, where these fellas are just jam-packed into the lesion here, and there's loads of them. So you can see the way this one in the middle, the chronic active, this is what we think is probably the pathological equivalent of smouldering MS. So can we see this on a scan? And a bit like the grey matter, it's got a lot of research interest, but we wouldn't necessarily pick it up in the hospital. So the only way we could sort of say somebody has this is really, again, from the story, from listening to the person and listening to what they're saying to us. So what people might say to us is, I haven't had a relapse, my scan's fine, I've had MS for 15 years, 12 years, whatever the case may be. But over the past 4 or 5 years, I've noticed this very slow change in this symptom or that symptom. And because of this importance, researchers have taken this on. And what they've done, and this is an example of sort of an advanced MRI technique using mathematical modeling. And what you can see is this is sort of the baseline scan on the left, and they've outlined where there are some changes here in the red. The next scan across is taken after a couple of years, and they've grown a little bit more. So there's no definite new changes, but they're just slowly edging out bit by bit. And then as time goes by, they edge out a little bit more. So in a research setting, this can be done. And what this heat map on the right here just shows is the percentage change compared to the original. So in the middle, this seems to be pushed out. This new change is sort of smouldering from the middle of the lesion and then making it expand outwards. In terms of why that is, we showed that on the previous slide in terms of the immune cells, that they're sort of edging their way out bit by bit by bit. And we think there's a particular immune cell called microglia that play a role in this phenomenon. So I guess the follow-on from all of this is we know about this phenomenon now. and we have to think about treatment. Now, at the moment, there are many medicines that are in research stage or in trial stage or coming towards the end of what's called a phase 3 trial, which will be the last stage before something's approved. And many research settings and clinical trials are incorporating this idea of smouldering MS. We don't know at this point in time if there's definitely a medicine that tackles it, but it's certainly come to attention and there's much more focus on it. What we do know, however, is that from research on animal models of MS and other models, that exercise does play a role in dampening this down. So what we know from human trials, not in MS, but in other human trials, that any form of exercise, as long as it's regular exercise and within the person's capability, does have a very positive effect on brain function. And then what we think is that because of the mechanism that this works, that humans exercise or exercise more generally would have a positive effect on slowing down this smouldering phenomenon. So in St. James's, what we would often advise when we pick this up would be linking in with our physio. And we have an MS specialist physio, Gillian, who works with us. And we try and get people involved in an exercise program. And what Gillian does is she runs one-to-one sessions, and then for the longer term, for maintenance, there are a series of online or Zoom exercise groups, which encourages people to keep going, so that one of the key things with exercise is that it's done on a regular basis, and it's not, a big burst followed by none for a period of time. So it's kind of keeping something going at whatever level of ability, and the main thing then would be that it's regular. So to kind of conclude from that, there are three things really that I thought I tried to highlight in this talk. Firstly, the rate of change of white matter lesions is the most important factor in the yearly scan result. So it's never how many there are or how big they are, it's whether there's been a change. So whether there's been an increase in size or an increase in number. And if things are stable, that's generally good news. Secondly, we know that grey matter changes on a scan, they're mainly seen in research at the moment, but new techniques such as those we're trying to develop in St. James's hopefully will improve this in the future. And we think that that'll be very important, particularly in relation to diagnosis. The third point then is that smouldering MS, it's a new concept over the past number of years that's used to describe some very slow changes that do occur in MS without MRI changes or definite relapses. And that's the end of my talk. So thank you very much for your attention, and I'm going to stop and sharing my slides now.
That was wonderful, Dr. Kearney. Thank you so much for all of that information. Smouldering MS is just such an interesting topic as well, and thank you as well for delivering it in such an accessible way, because it can be very difficult to find accessible information on smouldering MS. We have quite a few questions in,
sure.
So we might just get to them. So, sorry, I just better scroll on down. We have a question. If a person has a tumefactive MS presentation, do they generally have a poorer prognosis?
Not necessarily. So what we know with tumefactive MS, really one of the key things is at the diagnosis to think about things, because when you see something, the reason it's called tumefactive, first of all, is that the lesion mimics a tumor or looks like a tumor, and it can cause a huge degree of concern. So we know with advances in scanning and other techniques that trying to get a diagnosis of MS is really the key starting point. What we know then is if we follow people who've had that at the beginning, for the most part, that original very big lesion will shrink over time. And then the key point is having the diagnosis secured to get on to treatment. And that's really when the MS nurse, in conjunction with the neurologist, is so important to talk through the different treatment options and get started on a treatment as soon as things are in place.
Thank you. And there's a question as well about the use of lumbar punctures. So are they still used, or have they been taken over by MRIs and other tools?
So that's a very important question. They're still used, and what I mentioned was in the middle of the talk was about these rules called the McDonald Criteria. And like many rules, these have evolved over time. And there was a point in time where lumbar puncture was taken out of those rules, but it's back in now at the moment, and it plays a very important role. And the reason it plays a very important role is it's really the only way we can sample the fluid and see what's actually happening in terms of the biology of the cells. And what we would be looking for in a lumbar puncture is to look for signs of inflammation that are in the spinal fluid but aren't in the blood test. And that's really important because if we see signs of inflammation in the spinal fluid but not in the blood, it gives a lot more confidence that what's in the scan is definitely a pattern compatible with MS, and it helps us to rule out a number of other conditions, because as I showed in the image, many scans can mimic MS, and you have to be so careful if you're not sure, and the lumbar puncture test is really important in that regard.
Thank you. There's a question from somebody here. They're wondering if you've had recurring symptoms like numbness in your leg, does that actually mean you're having a relapse? Even if not serious, does that technically mean that your medication is not working for you?
I think the key thing really in terms of trying to figure out if it's a relapse or not is if it's new. And that's really the starting point. So what you would do, I suppose, in clinic with your MS nurse or with your MS neurologist would be talk about what happened at the beginning. What was the first thing you noticed that changed? And then if you can kind of build up a picture of what was there at the very beginning, try to figure out, are these changes happening as very new, as brand new things, or is it the old things coming out to the fore? And if it's the old symptoms coming out to the fore, it can be for lots of reasons, but the most common thing is if the person's body is under some sort of stressor. And that can be an illness, it can be general stress in life, it can be fatigue, it can be a change in other medicines, or heat, for example, is a very common reason. So it comes down to sort of delving into the detail and really by talking about things with the MS nurse and neurologist to figure that out.
Thank you. Somebody asked earlier on in an earlier session as well about interventions for pain, I think neuropathic pain as well. Would you be able to just maybe give a quick overview of interventions that might be available to them?
Sure. Well, I suppose the first question is, why does the pain occur? So what we know is pain in MS is common. Thankfully, not everybody gets it, but many people do. And it can be quite a debilitating symptom. As was discussed earlier in the day, if you have a sort of chronic pain, it can add to fatigue and it can add to a change in cognition. So it is an important thing to address and to treat as much as possible. We think it happens because MS involves the spinal cord. And when a change in the spinal cord occurs, this is an important pathway in our perception of sensation. And if that link is broken or not working fully, rather than getting a normal sensation, a painful sensation can arise. So many people will be familiar with the feeling of kind of this tight belt or squeeze around their middle. And that's a symptom of involvement of the spinal cord. Some people can get shooting down a leg or an arm or an unpleasant tingling or pins and needles. And these are sort of examples, and it can be very distressing. What we would do is, if somebody tells us these symptoms, we talk about treatment. Now, unfortunately, we don't have a dedicated treatment for nerve pain, and we tend to borrow from other medicines. So we mostly borrow from anti-seizure medicines to treat it. And broadly speaking, what anti-seizure medicines do is they dampen down how excitable the nerves are. So there are many examples that people might be familiar with. So an example would be a drug called Lyrica, or the generic name is pregabalin. Another example would be Neurontin, which is known as gabapentin. And then we also would sometimes use antidepressant medicine, a medicine called amitriptyline, or sometimes duloxetine. And after that, there are other options, which would include applying creams. There's a cream derived from chili peppers called capsaicin, which can be applied above the site of the pain. And the idea there is to sort of trick your body so your body feels the heat of the chili, but not the pain beneath it or below it. And that's, they're sort of broadly some examples. Many neurologists will be aware of these things, but for some people, the pain can be more complex, and it might also involve linking in with a pain specialist or a pain clinic. So it very much depends on the person and the level of discomfort and the impact on their life.
Okay, and it's interesting there. So is it an MS hug? Is that what you were kind of describing, that kind of banding sensation?
Exactly.
So that is something that people should report to their neurologist if they experience.
If it's causing them discomfort, absolutely, yeah. Because I suppose, you know, even the term itself, the MS hug, has been up for debate as to whether you know, because a hug is usually a nice thing, I guess, and this isn't a nice thing. So I don't know what the best name to put on it is, but I think generally when you use those words of a sort of tight band or like a belt or a squeeze and sort of around the midriff, people with MS would often be able to identify with that. And like many MS symptoms, it can come and go. You know, there could be periods of times where it's very prominent. If, for example, if somebody has a bladder infection, it might really ramp up. But then if all else is equal and the person is well rested, well hydrated, and going through a good patch, it mightn't be there as much. So it really depends, you know, how much it's impacting on the person. And then it's a case of trying to figure out, is it an appropriate thing to use one of these medicines? I think the thing with any medicine we always have to bear in mind is there's pros and cons with them. And the pros of these medicines I mentioned is that they can dampen down pain and discomfort, but the sort of things against them is they're all medicines that work on the brain, and they have a sort of a general effect that they can, in some instances, add to sort of clouding the brain a bit, if you like. So you always have to have this trade-off between what's the minimal amount of the medicine we can get away with, but at the same time keeping the symptoms under control. So it's kind of, you know, a bit of a yin and yang kind of a thing.
Yeah, it's such an interesting one because, you know, we're like with reporting a relapse, it's something that's lasted for more than 24 hours in the absence of infection, high temperature and so on. But with an MS hug, because it's a transient thing, people might not always think to report that.
Yeah, I think a key thing with it probably would be if you've never experienced it and then it occurs, then that's kind of suggesting that something's active, something's there. Do you know, because if it's something that's been there since the beginning and it's coming and going, it might be sort of the circumstances. But if it's a brand new thing, that might suggest that the MS is active and there's a change in the spinal cord that hasn't occurred before. And that would be worth noting to your MS nurse or your MS neurologist so that they're aware, and then in due course review the treatment and discuss options.
Thank you. A question here, can the location of lesions detected in the white matter provide information or predict where symptoms might be likely to occur?
To an extent they can, but they don't perfectly match up. So when I say to an extent, so for example, the spinal cord would be a good site to think about, because what we can see lesions in the spinal cord and we can do scans there at the diagnosis, the level where the lesion is doesn't match up with the place where the symptoms are occurring. We don't quite know why that is, but we think what's happening is the lesion is kind of the tip of the iceberg, if you like, but we're not seeing everything beneath the water. Similarly, in the brain, we see sort of the bits that really stand out in the white matter, but because we know the bulk of the disease is affecting the grey matter, and we're not seeing that as much, we're again sort of seeing the tip of the iceberg. We know that in terms of prognosis, so if somebody's newly diagnosed with MS, we know that lesions in some locations have more of a role in prognosis. So lesions that are at the lower part of the brain stem, or the back, which is the cerebellum, or the spinal cord, probably play more of a role in prognosis. But once the diagnosis is established and somebody has definite MS, it's often very tricky to definitely say that this lesion here is causing that symptom there. And it's seldom that you can actually go as far as saying that.
Thank you. And I read it a second ago. Oh, sorry. How sensitive are your MRI scan comparison? So from 1 year to the next, how sensitive are the MRIs in terms of being able to pick up changes?
I think the thing to say here is it depends on the person who's reading it. So it's only as good as the person reading it. So what you have to kind of think about is an Irish hospital. You know, there's a radiologist, they're asked to be reporting CAT scans from people with other diseases, chest x-rays, MRI scans. And then in the course of a busy day, lots of nurses or doctors might want to talk to them and run into the room and say, oh, tell me about this, tell me about that. So if you're trying to carefully look through a scan from 2 years ago and then the current scan, it's possible that you might have a few interruptions in that can break your train of thought. And then you have to sort of bear in mind that there are technical reasons why a scan might look different too. So you have a lot of things to factor in. So I think generally what happens is the doctor who's requested the scan will get a report. And if there's any doubt about it at all, this is where the meeting between the radiologist and the neurologist is so important, because you can then give a clear sense to the radiologist that I think this person is having new symptoms or new changes, and then look at the scan again and have a better look in a bit more detail. And then in that kind of environment, you can kind of come to a conclusion, or a decision could be made as to whether the scan reflects activity or not. So it does, you know, it's like many things in life. It's fallible because it depends on a human. And there are big pushes at the moment in many centres to incorporate artificial intelligence into reading the scans. And it's something that I think is interesting, and I think has the potential to help with the process, not a replacement for the radiologist, but simply to give an add-on, so that there's a way of using an automated system that takes out the human dimension just for counting are there new lesions or not.
How often should spinal MRIs be done, and is serial scanning recommended? Is it important to have an MRI on the same scanner?
Yeah, so I suppose the first question really is about spinal scans. We know that the spinal scan is really important for the diagnosis. Then if you come to doing it on serial scans again and again, scanning the spine is technically much more challenging than scanning the brain. And there are a few reasons for this. If you think about your spine, you have your heart and your lungs lying in front of it, and then you have your tummy down below. And all of these things move. And anything that moves can create a pulsation. So your heart, every time it beats, it creates a pulsation, and your spinal cord sits in fluid. So it's like throwing stones into a pond. It creates a ripple. And that can lead to artifacts or changes. And the thing is, if you see an artifact, it's very hard to know, is that a real definite MS change or is it an artifact? So you can very often get into this scenario where if you scan somebody's spinal cord, it's hard to say this is 100% definitely a new change, and you might end up doing a repeat scan and then repeating it again, and it can be quite intensive in terms of the worry for the person. Do I have a new spinal change? Is it real? Is it not? And then in terms of the hospital itself, the resources required. So the international guidelines, which were published last year, it's two consortia. One is called NAMES, which is North American Imaging in MS, and the other is MAGNUMS, which is a European consortium, came together and wrote a position paper. So these are two large, a European and North American consortia came together. And what they said is that they gave guidelines on how the brain should be scanned once a year, but they say that at this point in time, they wouldn't recommend scanning the spinal cord on a regular basis. And I suppose this does vary from centre to centre, neurologist to neurologist, and radiologist to radiologist. So there is great variability. I think one thing to say is if you're in a centre where your spine is being scanned, MRI is a magnet, there's no X-ray. So there's no harm that's going to accrue if you have lots of scans. So you get 10 scans in a year or 1 scan in a year, it's not going to do any harm. It's a magnet, it's temporary, and it's not like X-rays at all. Whereas if on the other hand, the focus has been on your brain, then that would be sort of in line with the international guidelines as they stand at the moment.
Thank you. And you'd said earlier on about it being difficult to detect lesions, let's say, in the grey matter. And the question came in about the use of a contrast enhanced scan. So would that be useful in helping to identify active lesions in grey matter, or is that still, like, even with contrast, it's still difficult to detect?
There are a few different differences between the grey and the white matter, and one of them is that even though the loss of myelin is greater in the grey matter, it's not as active or as inflammatory, if you like. So if you give contrast and a lesion lights up, it'll only be a lesion in the white matter. So the contrast agent won't help you with the grey matter, even if somebody has very, very active MS at that point in time. So because it's this sort of slower burning phenomenon in the grey matter, it's a case of trying to see it as well as you can. And there are many different approaches, and I suppose MRI has been on the go for quite a while and it's well established, but there are newer technologies such as PET scanners. And a couple of research groups are looking at PET scanning to see, could that improve picking up things in the grey matter? And then people are looking at other techniques and other approaches. So it's certainly a work in progress. And I think the international research community are well aware of the challenges and trying to come up with newer novel techniques or ideas to sort of get there.
Thank you. There's somebody here who says that they were diagnosed with MS 40 years ago with few symptoms. They've recently been diagnosed with MOG. Is there a relationship between smouldering MS and MOG?
So I suppose MOG stands for myelin oligodendrocyte, or sorry, it's MOG is what it's commonly known as, and it's an antibody mediated disease. So it's a bit like neuromyelitis optica. It's a sister disease of MS. And so if the person's neurologist has said that they have MOG antibody associated disease, or MOGAD as it's often known, then I suppose this might mean that the diagnosis is being reevaluated, and there are implications for treatment then, because the treatments for anti-MOG antibody associated disease do differ from the treatments for MS, and that's something that probably has to be discussed quite carefully with their neurologist.
Thank you. And somebody asked as well, do you think it's worth asking their neurologist about potential grey matter impacts during their annual appointment if their scan looks clear but they're experiencing symptoms?
I think, I suppose when you have your appointment, it's every and any symptom that can be discussed. There's kind of nothing that's off limits, really. And then it's more, the tests are really reflecting what the person is showing or saying, sorry. So in terms of symptoms of grey matter changes, well, what we know, for example, is that cognition and changes in cognition probably are reflected in research setting by a loss of volume in the grey matter. So that seems to be how it matches up to the grey matter. But in a hospital scanner and in sort of a routine scan, you won't necessarily be able to comment on a loss of volume on the scan. So whilst you can't comment on the scan, you can focus on the symptoms and then see how can we tackle those symptoms, in terms of either linking the person in with occupational therapy, psychology if it's available, and then with their MS nurse as well. So I think the key thing is to sort of have an open discussion with the MS nurse and the neurologist about whatever the concerns are at that point in time, and to sort of bear in mind the scan shows some things, but it's like many things in life, it's not perfect and it won't show everything. And so, and that can sometimes be a source of frustration. Why am I getting worse? But my scan is the same. And I think it's important to talk that through and consider sort of there is a technical side to the scanning that it doesn't pick up everything that's going on in the person's world.
Thank you. So there's a question here from somebody as well. If triomyalgia is linked with MS?
I'm not familiar with the term itself, I have to confess. So perhaps, could it be trigeminal neuralgia? Is that
It
maybe?
could be trigeminal neuralgia. Yeah.
Okay. Yeah. So If it's assuming it's trigeminal neuralgia, then very definitely it could be linked to a lesion in the lower part of the brain. So the trigeminal nerve is a nerve that goes out to supply the face. And if there's a lesion where that nerve begins at the base of the brain, that can cause a shooting or electric type of pain into the jaw or into the cheek or across the face. And it could be a very distressing symptom. It's relatively common in MS, but it is treatable. And the treatment is with an anti-seizure medicine called carbamazepine, or Tegretol is the other name for it. And it tends to be quite effective. Now, it doesn't work in every case, and there are some people's cases where other medicines have to be added in. And so there's sort of a routine list of medicines that can be used in the case where it doesn't respond to Tegretol.
Okay. Somebody's asked if there are any strategies to manage smouldering MS.
So I guess I kind of talked a small bit about it there, that exercise is so important. Now, I suppose in terms of an exercise strategy, one of the things that Gillian, who's our specialist MS physio in St. James's, would often say is that it's not what the exercise is. You know, it doesn't matter if it's ballroom dancing, it doesn't matter if it's yoga, it doesn't matter if it's running or whatever you're able to do. It's really continuous and regular exercise is the key thing. So I suppose that's sort of what we have in the here and now. The other thing we can do is sort of look at the other diseases that affect the person. So things like, for example, checking blood pressure, checking blood sugar levels, and checking cholesterol levels. These are all very important. Looking towards the future then, a lot of the newer treatments are going to be focused on, or these are treatments that are coming on stream relatively soon, we hope. Their early results are hinting at that they might tackle these immune cells called microglia. And these are the guys I showed on the pathology slides that are sort of edging away at the edge of these smouldering lesions. So that might become an option in the short future.
Thank you. Just to say as well, Dr. Kearney, there's lots of comments as well in the chat. People have really enjoyed your presentation and the Q&A as well. I'm just going to maybe ask one final question. I'm just conscious of time. And the question is, when do you expect grey matter study to become a commonplace part of diagnosis?
Well, I suppose what we can say is at this point in time, if grey matter change is seen on a scan, it can be included in the rules, the McDonald criteria as are. So they do allow for picking up grey matter changes. Now, the thing is, as I was saying, it's very challenging to see them. So I suppose it's a case of when will we have a scanner technique that can be rolled out across every centre in every hospital that can reliably pick them up. In terms of a bit of context, I suppose, research on the grey matter, it's been going on probably for about sort of the past 10 to 12 years, looking at various different types of scans, strengths of magnet, all these kind of things. And to date, there hasn't been sort of a uniform approach that's sort of gained traction in a hospital setting. So I suppose every sort of researcher who's focused on this area is trying to sort of do their best to add this information. And that's one of the things we're trying to do with our research in St. James's, is that should our approach, and it's not to say that it definitely will work, but it's just trying to target things in an area where we know from the post-mortem studies that the greatest number of grey matter changes occur, and maybe sort of, I suppose, going where the money is, if you like, because we know that's where, if you think about MRI as a picture, it's really a mathematical model of what's actually happening in the brain. And so it's all about where you look and how you look. And there is, you know, with advancing technology, we know that scanners are going to get quicker. We know that the resolution will improve. And so the way things are now, a bit like any computer, it's really evolving rapidly. And as that technology improves, then I'd be very hopeful that in the future, it would become a routine thing to pick up grey matter changes in terms of accounting for the diagnosis.
Thank you very much. That just brings us to time. Were a few questions that unfortunately we're not going to get the time for on this occasion, but Dr. Kearney, thank you so much for a wonderful presentation and for answering so many of the questions. It's going to make a fantastic resource on our website as well.
Great.
So thank you so much for taking the time to come and talk to us today.
Not at all. Thank you for the invite again.